And we have two excellent presentations. The first one is from Professor Faselis. He's a professor in George Washington University and Chief of Staff in Veterans Hospital in Washington, D.C., with a very attractive title, A Leap Faster Than Decay, Nature's Randomized Trials and a New Era for Cardiovascular Research. So maybe we can have a critical point of view between the traditional randomized clinical trials and the new approach, the Mendelian type of trials. So could we have the Dr. Faselis lecture?
Good afternoon, everyone. I would like to thank the Hellenic Cardiology Committee, especially Dr. Grasos and Dr. Gunevenos, and some of my collaborators in the Hellenic Cardiology Society. Thank you for inviting me. I'm going to start and talk about Mendelian randomizations, or nature's randomized trials. And the title comes from Odysseus Elitis, one of my all-time favorite Greek poets. And in Greek, it has to do with decay. In this case, the decay associated with randomized controlled trials and the money we spend in that area. A 74-year-old man is seeing you for a follow-up, and this person is in a randomized controlled trial. He develops transaminitis. His question to you is, could this have been somehow been foreseen? Meaning that the transaminitis. And the answer is, 11 years ago when this patient was in my office, the answer is no, but now we probably could with Mendelian randomization. So the background is that randomized controlled trials are the gold standard. They have developed background information on efficacious therapy and reduction of cardiovascular disease has been the result of these efficacious therapies that have been studied by a randomized controlled trial. Despite that, cardiovascular disease, such as ischemic heart disease, is still the leading cause of premature death and disability worldwide in 2019 and definitely going into the third decade of the 21st century. Despite all the things that I'm going to say here, randomized controlled trials are still the most reliable evidence of efficacy of therapeutic interventions and the causal role of biomarkers targeted by the intervention in disease risk. But they are costly and high risk. We need about $85 million to conduct phase 1 to 4 of a cardiovascular study and to produce a cardiovascular drug in 2020, about $2 to $2.5 billion. So this is not practical unless you have background information. And in some cases, it's not ethical. And I like to give the example of the J-shaped relationship cardiovascular curve that we had seen 20 years ago. You can't randomize people to a higher blood pressure. It would be unethical to see if they develop cardiovascular effects. And with good reason, because randomized controlled trials further down showed that this is not the case, and there is really no J-shaped relationship with cardiovascular disease. So what do we do when such data are unavailable? We look at classic observational epidemiologic studies, and my collaborator, Dr. Kokinos, and I look at sometimes millions of patients trying to get to the answers of certain clinical questions. But despite this, and I'm not trying to downplay classic observational epidemiologic studies, but they are prone to bias. They have confounders, there's reverse causality, there's information bias and selection bias. And here's just a small example of some things that we see with observational studies. And the first one, the relationship between smoking and yellow teeth and lung cancer, of course, is a confounder. This is the famous question that Dr. Trichopoulos in Athens Medical School used to ask us about, yellow teeth or yellow fingers, and then sometimes a reverse causality on CRP and cardiovascular disease. It's really cardiovascular disease that causes CRP and not the other way around. So a lot of biases in observational epidemiologic studies that have to be taken account for. And what do we do then? Well, we tried to look for alternative non-interventional approaches. And one of these is Mendelian randomization. Randomization is the use of a genetic variant to look at certain biomarkers that cause disease. And this in recent years has been significantly facilitated by improved genotyping platforms, analyzing millions of SNPs, these single nucleotide polymorphisms. Now, on top of that, there's global genetic consortia and databases. And then we can produce reliable identification of these SNPs. 20 years ago, this wasn't an issue. So what is a Mendelian randomization study? In simple terms, Mendelian randomization is one where genetic variants are used to investigate the causal relationship of a biomarker on the risk of disease. The concept was first described by Dr. Ketan in 1986 in relationship to cancer. At the time, there was concern from observational data that blood cholesterol lowering may lead to altered risk of cancer. And Dr. Ketan suggested at the time using genetic variants in the APOE locus, the one associated with plasma cholesterol concentrations, to assess the causal role of cholesterol with cancer. He didn't call it Mendelian randomization at the time, but he brought that idea. And of course, as you know, there is no association with cancer and lowering cholesterol. It was just a confounder at the time. Dr. Ketan, who is out of the University of Amsterdam, has noted in the last couple of years that his editorial in The Lancet in 1986 has gotten him more notoriety than any of the other studies he has ever done. So the fundamental principles of Mendelian randomizations are the genetic variants that either alter the level of a modifiable biomarker that is the causal in disease. The disease risk is the effect of the genetic variant on the biomarker. Take, for example, LDL cholesterols. They are biomarkers, that is the LDL cholesterol, that is affected by a gene. Certain people have a gene that lowers their cholesterol. Those people, these genetic variants, with stronger effects on LDL cholesterol, have a stronger relationship with the risk of cardiovascular disease. So if there are variants that lower your cholesterol, your risk of cardiovascular disease is lower. If there are genetic variants that don't affect your LDL or make it higher, then your risk of cardiovascular disease is higher. And Dr. Ferenc, who was a cardiologist at our institution some time ago, showed this in a JACC paper in 2015. Why do we refer to these analyses as Mendelian randomization? Well, the name Mendelian randomization refers to the random assortment of alleles during meiosis where DNA is transferred from a parent to the offspring at the time of gamete formation, a process named Mendel's second law. This means that the inheritance of any particular genetic variant in an individual's DNA should be independent of all other characteristics. In a way, the easiest way to understand Mendelian randomization study design is by way of analogy to an RCT design. And indeed, Mendelian randomization has been described as nature's randomized trial. I will take you to the slide, which is probably the most important slide. You could look at the conventional trial on the left. A sample is taken, a randomization is done, people are given a statin or the control, and then you compare that to Mendelian randomization where you have a population. Now you have random allocation of alleles. One has a genotype group A, which causes the LDL to be lower. These people have a lower cardiovascular event rate when you compare them to genotype group B, which doesn't affect the LDL. So very important, nature's randomized trials. We can use this to answer a lot of our questions. So why are there advantages to this? Well, it's done quickly. It doesn't cost a lot of money, but also look at this. The genetic variants are non-modifiable. They're not influenced by confounders. If done correctly, measured with precision, this is a very precise way to measure outcome in terms of the biomarker. And these genetic differences in biomarker, if remain untreated, remain constant. So somebody has these genes, they have them for life. So let's focus on, okay. Έχω 2 λεπτά από το. The last few slides are the most important because in terms we look at recent applications of Mendelian randomization. They have become more prevalent in the literature. In 2020, there were 680 Mendelian randomization studies. In 2012 and 2011 altogether, there were about 48. They're quicker and cheaper to conduct the randomized controlled trials. They utilize existing data and they focus on 3 areas of utilization, efficacy, predicting adverse events, and then redistribution of drugs. Predicting efficacy is very important because genetic support of drug target can enhance the probability that an RCT succeeds. Take this case of a phospholipase A2. This is an inflammatory biomarker, and if you look at the data right here, the loss of a function in a gene that codes this was documented in 2011 at a biobank in China. Well, people spent $2.5 billion developing this drug, daraplabdib, that was presented in JAMA, New England Journal, in 2014 that showed that the studies were negative. Well, if they would have looked at this biobank, they would have done the analysis that Middlewood did for Jack in 2016, and they showed that the trait was not associated with major vascular events and other vascular outcomes, so they should have never probably have done the study. Predicting target-mediated adverse effects, you will hear from Dr. Kokinos about type 2 diabetes and statins. Well, we can use Mendelian randomization to show that both ezetimibe and PCSK inhibitors also have the same diabetogenic effects. Not only statins, it's an effect of HMG-CoA reductase. And these has been shown in multiple studies. And then lastly, repurposing of drugs. How important is that, especially now with the COVID pandemic, if we can find drugs that we could use for other purposes? With a phenom-wide scan, we could use these biodata banks to basically tell us if we can repurpose drug and use them in other ways. In this case, daraplabdib was not fruitful because we looked at repurposing daraplabdib and basically it did not find that there was any way to repurpose this. In summary, particularly successful Mendelian randomization is particularly successful in cardiovascular epidemiology. It can be applied when the exposure is modifiable behavior rather than a biomarker, but especially in biomarkers, and gives us a lot of tantalizing opportunities to identify potentially modifiable exposures. Extremely valuable as they use existing genetic data to provide qualitative information of treatment efficacy. And with that, I thank you for your attention.